I think we are live, so we can start with the session. Good evening, everyone. I hope all of you are doing good. It's a bit wintry out here. Uh, Provided you are in the northern parts of the country, we both are sitting in the north part. So, I'm Dr. Sandeep Sharma. I'm the pediatric faculty at DocTutorials, and I'm privileged to invite Dr. Pallavi here with us. Dr. Pallavi is our dermatology faculty, and together we are going to take the integrated discussion on skin and nutritional deficiencies. The topics we have selected, we'll keep it very short, very crisp, but we'll be covering at least 8 to 10 actual MCQs of NEET PG, FMGE, INI-CET. Plus, we will be discussing some of the relevant points which you might be needing, which you might be knowing, but at the end of the day, some of the points tend to get, skipped out when you are preparing or when you are revising them. So, first of all, welcome, ma'am, to this session, and good evening.
Good evening, sir, and good evening to all of you attending this session. It's a very nice winter evening out there, one of the coldest days of the season. So a good time to have a warm chat about nutritional deficiencies with you all. And if you look at the last 5 years NEET PG papers, every year at least one question on nutritional deficiencies is asked. INI-CET, more of concept-based questions around it. So this is very relevant to your clinics as well as the questions in the exams.
So because there are 1 to 2 questions being asked every year, and generally these are image-based questions, so our focus will be on the image-based questions. We'll not try to teach you pathophysiology unless and until it is absolutely essential. Many of you may be having doubts after this session, or you want a particular information. Some of the things which we are telling, they are updated. They may not. They may be in variance with the older information. You're most welcome to reach out to us. You can see the scan code of Dr. Pallavi. She is active on Instagram. You can reach out to ma'am, and I'm also active on Instagram. So these are all Instagram profiles. You can scan and you can reach out to us. Whatever doubt you have, you're most welcome. So without wasting any time, let us start with the session. Thank you, Dr. Vandana Puri, ma'am. Ma'am is also watching the session, although ma'am doesn't need to, but thank you so much, ma'am. Let us start with the MCQ scenario. Look at this MCQ scenario when this question was asked in the exam. This is very similar to the actual question. A lot of people, their eyes virtually lit up and they were like, oh, ye to aata hai. Immediately they marked only to get negative marking in the paper. The following condition can be seen due to all of the following except. What are we seeing here? What we are seeing is what you call as Castle necklace. Castle necklace is typically described as the manifestation of pellagra. Pellagra occurs due to niacin deficiency. This is something we already know, but question is asking except. So does it change the answer? Yes. Castle necklace typically occurs in pellagra, but it can also occur in tryptophan deficiency. It can occur in mimics like carcinoid syndrome, and it can occur in Hartnup disease, which is a type of inborn error of metabolism. Tryptophan excess does not produce it, and so B is your correct answer. This is the mistake we all make. That is why we have particularly chosen questions like this. If you just listen to the session, it's not a replacement for your existing preparation, but it will make sure that you know the pitfalls that you make in the exam. So, ma'am, let us go into the world, and ma'am will be teaching you about pellagra. So,
Sir, a very relevant question here and often asked in the exam. So can we go back to the question?
yes.
As you go back to the question, what you see in the image, you see a rash which is on the face and the neck. This is a V-shaped rash. So whenever you see the distribution, if you notice that it is on exposed parts, especially those that are exposed to sun, you have to think of etiologies that may have a photosensitive rash. And this rash here is only telling you that it is photosensitive. There are multiple causes of a photosensitive rash which are listed right in front of you. Niacin deficiency, which causes pellagra, is a very important cause of that. And so are the others listed in the question here, like carcinoid and Hartnup disease. Now, just based upon the image, it is not possible to differentiate. So look at the question. It's not asking you to differentiate. It is only asking you which of these conditions can show a photosensitive rash. Now, moving to pellagra, this happens due to deficiency of vitamin B3. 3, that is niacinamide or niacin. A very important deficiency that you need to know, more often seen in people who may be chronic alcoholics or those who have a maize dominant diet. Sometimes people on ATT also may have this rash. So these are the common predisposing factors where you see a rash of pellagra. But apart from the rash, there is an important triad that we need to remember. We all have read it throughout our MBBS. These are the 3 Ds. It starts with diarrhea. So the first manifestation of the disease is diarrhea. Patient goes on to develop an itchy photodistributed rash. So you will see the rash on face, neck, hands, which are the areas that are exposed to sunlight, and it is itchy. If untreated, patient goes on to develop irritability, lethargy, and ultimately dementia. Untreated, a fourth D adds, that is death. So remember the 3 as well as the 4 Ds of pellagra. If untreated, it leads to death. Now, what are the skin manifestations? You see a rash which is photodistributed. So on the neck, when you see this V-shaped rash, this is called as Casel's necklace. And a similar rash you can see on the hands and the wrist. It actually has a sharp cutoff on the wrist based upon the clothes that you're wearing. This rash on the hands and the wrist is similar to the metal gloves which were worn, in the older times by villains or someone who was working with heavy machinery. So this metal glove used to be called as gauntlet. And because this rash is in the area which is similar to that, it is also called as gauntlet sign. So these are 2 signs which are named signs that you have to remember: Casel's necklace and gauntlet sign.
Think of Thanos. Those who watch Marvel Cinematic Universe, Thanos had a gauntlet in which he put those mystery stones, and then he was like, did like this, and half of the population evaporated. Those who watch Hollywood movies, they would know what I'm talking about. That is why we call it as gauntlet sign. For those who don't watch Hollywood movies, it's okay. You don't like to think about that. You can simply remember the description which ma'am gave. Castle necklace, everyone knows. Gauntlet sign, people do not know. This is a very, very important point. Again, we want to emphasize, sometimes topic is repeated, atypical thing gets asked. Gauntlet sign is not there in pediatric notes, it is not in pediatric books, it is there in derma books, and that is why we are doing a integration over here. Also, somebody is asking about alopecia. Please remember, alopecia is not a feature of typical pellagra. If you have alopecia mentioned along with diarrhea, dermatitis, etc., you have to think of other micronutrient deficiencies. If the rash is on the face and rash is in the perigenital region, along with diarrhea and alopecia, you will think of zinc deficiency, which we will be coming to in some time.
So in
So,
fact, that reminds me of a question which is a NEET PG 2021 question, that they gave an image of Casel's necklace and asked what can be associated with it. So there was diarrhea, dementia, alopecia also in the option. Which of these cannot be associated? So alopecia was actually the wrong point and it had to be ruled out. So please remember your triads properly. This is always a confusion. It is DDD in pellagra, while acrodermatitis and enteropathica we'll shortly cover. We'll tell you about that. But here it is DDD. There is no A here.
yes. And there is as the question started with the differential diagnosis of pellagra, are there any other manifestations which can have a Castle necklace? The answer is yes. There are 2 important ones. One is carcinoid syndrome. Carcinoid syndrome is a syndrome which is produced due to excess serotonin production. Serotonin is also written as 5-hydroxytryptamine. It is produced from carcinoids, which are neuroendocrine tumors. These patients will have, how to differentiate it as carcinoid syndrome? Look at the keywords. They will have Casel's necklace like presentation, plus they will say these patients will have flushing, intermittently flushing or episodic flushing is a feature only of carcinoid syndrome. It is not a feature of pellagra. Plus, these patients will have watery diarrhea. Diarrhea can occur there also, but they will be very specific. Watery diarrhea. Again, this watery diarrhea is episodic in nature. Whenever they are talking like this, plus minus other manifestations like weight loss, plus minus congestive cardiac failure, you will think of carcinoid syndrome as the likely TD in such patient. You can get a case scenario on this. Second differential diagnosis is Hartnup disease. It's an inborn error of metabolism, which is autosomal recessive inherited. These patients have SLC 6A19 gene mutation. 6A19 gene codes for a neutral amino acid transporter. Due to the deficiency of this amino acid transporter, these patients will have severe tryptophan deficiency. And due to the severe tryptophan deficiency, they can have pellagra like manifestation. Now, remember, these patients not only have a problem in the absorption through gut, there is also difficulty in reabsorption through the kidneys. And so, how to differentiate Hartnum disease? They will have pellagra like symptoms along with ataxia, along with amino acid urea. So if examiner is saying positive family history, young age of onset, ataxia with amino acid urea, your diagnosis will go in favor of Hartnup disease. Write down these points to your notes because we never know examiner is going to up the game at any time. So remember the usual 4Ds. Pellagra is the likely answer. If they say pellagra like symptom with episodic flushing, weight loss, CCF, carcinoid syndrome is your possibility. Pellagra like symptom, ataxia, aciduria, Hartnup disease is your possibility. So this covers every single MCQ which has been asked. We are not trying to, make it too academic. Most of the questions which have been asked, we have covered over here. Ma'am, anything to add or should we go ahead?
So management of pellagra, let's quickly
Yes.
tell about that. Yes.
Ma'am, management of pellagra, generally pellagra can be easily managed. You have to put the patient, unless there is feature of malabsorption, you can treat them with oral B3 supplements itself. And in oral B3 supplements, according to pediatric textbooks, the dose ranges between 50 to 300 milligrams per day. Generally, about 1 week of therapy is good enough. IV-B3 is recommended to be used only if the patient is having any feature of malabsorption. Otherwise, it is not recommended. And maize use needs to be reduced also in the patient, but it's not a part of the standard management. Let's go further, ma'am.
Yes, sir.
So we have another case scenario. Infant presented with perioral, perianal, perigenital rash. So you can see the description of the rash here, the morphology of the rash. There is also alopecia, there is diarrhea. All of the following are consistent except, first of all, you have to make the possible diagnosis. Whenever you have a desquamative vesicobullous erythematous rash occurring in the cheeks, perioral, perianal, perigenital, sometimes on the hands and feet, that is zinc deficiency that we are talking about. And if it occurs in infant, we are thinking of a condition known as acrodermatitis enteropathica. Now, they are asking again, except this is very similar to a INI-CET MCQ. All of the following are consistent except, will acrodermatitis enteropathica have SLC6A19 gene mutation? Uh, I think it is SLC39A4 should be there, right? 39A4 gene mutation. This is seen in these patients. Low serum zinc level is seen. Increased risk of Candida infection, it is seen. What about alkaline phosphatase levels? Alkaline phosphatase is a zinc dependent enzyme whose levels are reduced. This is not seen. And so the answer to this question is D. Ma'am, let's do a quick review of the topic. Let's do a quick review of the topic. Acrodermatitis and
Acrodom Acrodermatitis enteropathica is due to deficiency of zinc. It is an autosomal recessive inherited disorder. Very important to remember the inheritance. It is autosomal recessive. Plus, the problem here is difficulty in intestinal absorption of zinc. So you need to know what is going wrong. Going wrong is the absorption at the level of intestines, which is due to mutation in the zinc transporter gene, that is SLC39A4. And coming to the clinical features, when you look at the name of the disease, that is in itself telling you what the clinical features will be. There is an enteropathica, means there is a problem with the intestines, that is enteropathica, and the rash that you see on the skin is acrodermatitis. So this is an acral rash that you see on the dermatitis, which is generally a periorificial rash. Now, this is about the skin. Coming to the other symptoms that are there in the disease, the other symptoms can be remembered as the triad. We were just telling you how to differentiate pellagra from acrodermatitis enteropathica. So there it was DDD, here it is DAD. So that A comes in acrodermatitis enteropathica. Remember from A of the disease, A here, this is diarrhea, alopecia, and dermatitis. Diarrhea is again the first manifestation here. Patient generally presents with chronic, persistent diarrhea. That is your hint towards acrodermatitis enteropathica. Alopecia, yes, there can be hair loss. Dermatitis, we'll just see. So these are all the clinical features that are there. Onset is another important hint that you get in the exams. Generally, breast milk, the zinc present in breast milk is better absorbed in the intestines. So first 6 months of life, or whenever the child is in exclusive breastfeeding, they generally do not manifest the symptoms. But as you start weaning, as you start supplemental top food, that is when the absorption goes down, the symptoms start appearing. So the age here would be more than 6 months, as would be mentioned in majority of questions. So that is something that you have to note. The triad is DAD. Now coming to the skin manifestations are generally periorificial. So you would see a rash on the face, around the nose and the mouth. You would see it in the groin and in the perianal area. So it would be a periorificial rash. For some children, it may also be present on hands and feet. The typical rash that you see is actually an erosive rash. That is the term that you have to remember. So when you look in the image, this is as if the skin is eroded, it is abraded. You will see redness, you will see a raw skin. So this will be erosive rash. And there might be some crusting, as you can see on the lesion on the neck here. So there is some crusting also on the lesion. When you have any erosion, there is going to be serum exuding from it. It can crust on the surface. So you see erosive rash, you see crusting on the rash, you see it in these typical periorificial areas. That should give you a hint that you are dealing with acrodermatitis enteropathica. And a cherry on the top would be the other symptoms of D and A that can be mentioned in the question. Sometimes even poor wound healing is mentioned, because all other enzymes which would depend upon zinc, there would be problems with those enzymes as well. Sir, what about the other systemic manifestations that the children can have, these
Ma'am,
babies?
apart from that, these children will have features like poor growth also. And these
Yes.
patients will have recurrent infections also because the integrity of the skin is compromised. So, recurrent infections. Zinc is a micronutrient which has antiviral and antimicrobial property. When COVID started, we started eating zinc. Was there any evidence? No, but we know that zinc can, have some mild, modest antimicrobial effect. And because the skin integrity is lost and all these, enzymes which are involved in the skin healing, they are compromised. So recurrent infections, particularly Candida albicans infection is common. Another common agent, Staph aureus, is common in these patients. So remember Candida, zinc, diaper dermatitis. These are all overlapping terms. Ma'am will be talking briefly about that topic also. So stay back. But poor growth, recurrent infections, and alopecia are the additional things that we generally watch out for. What about the investigation part? In investigation, generally we go for serum alkaline phosphatase. I'm writing in short ALP. Alkaline phosphatase is a zinc dependent enzyme. In patients like rickets, the levels are increased, but in acrodermatitis enteropathica, levels are low, sometimes even absent in a severe patient of these because zinc is not there, so enzyme is not going to form. What about this is useful as a screening test in these patients. So somebody asks you what is the screening test of choice in acrodermatitis? Answer will be alkaline phosphatase. Cheap, easy to do, good sensitivity. But if you have to do the diagnostic test, then obviously you have to go in for serum zinc level. Let me tell you, serum alkaline phosphatase in practice costs somewhere around 50 to 100 rupees. Serum zinc level is a costly test. It costs somewhere around 2000 rupees. So only when the suspicion is strong, you go for it. Serum zinc levels are low. And these days, mutation analysis is also commercially available because many types of mutations have been described in the zinc. Now, the treatment part, interesting thing to note. Ma'am told you that intestinal zinc absorption is deficient. But do you know that the supplementation which is done, it is always high dose oral zinc, and this needs to be given lifelong. The dose of zinc varies according to the textbook that you are reading. The medicine textbooks, the adult textbooks generally talk about absolute values, but in pediatric textbooks, you get a range between 3 to 5 mg per kg per day. Generally, the dose of zinc is 1 to 2 mg per kg per day in a normal child. So 3 to 5 mg per kg per day, it is given lifelong. Now, question may arise, कि sir, if zinc transport is not happening, the absorption is not happening, what is the point of giving oral zinc? When you give high oral zinc, zinc displaces the other ions like copper, like manganese, and starts getting absorbed from their transport receptors. Now you will say, कि sir, copper deficiency हो जाएगा. Copper deficiency does not happen because liver is a very, very good source of copper. And so what we do sometimes is we give zinc-free days also. We know you write 100 days of treatment to be taken, patient will never take 100 days, he will take 90 days, 80 days, 70 days. And so all the days that the patient leaves, those are the days the other micronutrients can be absorbed. It's a very crude way of saying this. There are technical ways, but again, we are here to pass the exam. If you take up pediatrics or if you take up dermatology tomorrow, you can read the fine points about it. Remember oral zinc, because lifelong, how can you give daily injection? So, ma'am, anything to add from your end?
No, sir, all good.
So it's a useful concept. Trupti is asking again, how will it absorb? I repeat, when we take slow dose zinc, then there is a specific receptor. But when zinc is given in high concentration, it gets absorbed from the other micronutrient receptors also. And that is the mechanism how it gets absorbed. So these are important points. We are not discussing pathophysiology, but where needed, if the question can come, we are trying to cover that. Let's move forward. Ma'am, your area, please take over.
Yes. So another question which can get confusing sometimes in the exam. This is an 8-month-old infant who presents with rash and diarrhea. What is the most appropriate management? I will wait for you to respond here. When you look at the image, what do you see in the image? There is maceration. You see the red raw area over the vulva. There is maceration, but there is another very typical lesion that you see in the image surrounding that maceration. Do you see these small tiny lesions in the periphery? What is that? What are those? That is what will give you the diagnosis. These small tiny lesions in the periphery of the rash. Any answers from any of you out there? Come on, give me an answer. So when you see these small lesions in the periphery, this hints towards what are called as satellite lesions. And where do you see satellite lesions in dermatology? One of the very important causes for that is Candidal intertrigo. Whenever you have a Candidal infection in the folds of the skin, whether it is neck, it's groin, it's toe webs, it's axilla, mammary folds, whenever you have a Candidal infection, there will be maceration, but you will see satellite pustules in the periphery of the lesion that takes you towards a diagnosis of Candidal intertrigo. Now, this as a question, I have mentioned that there is rash and there is diarrhea. So there might be a chance that you will be tempted to think of it as acrodermatitis and enteropathica, knowing that two of the features are there. You might end up marking oral zinc, but for this you have to look at the image properly. In the image, you see the satellite lesions, you diagnose it as intertrigo, and your correct answer would be clotrimazole cream. Betamethasone cream would be your answer if this was seborrheic dermatitis. That would show a yellow greasy rash. It would not show any satellite pustules or any satellite lesions. Topical zinc oxide, we were just discussing in the previous slide that it has protective activities for the skin. Where do we use topical zinc oxide creams? In babies, there is a rash in the groin where zinc oxide preparations are given. That is done for diaper rash. So this is to make you differentiate Candidal intertrigo from diaper rash. See, satellite pustules is obviously only in Candidal intertrigo, but what else differentiates it from a diaper rash? Diaper rash would be on the bulges. It would spare the depth of the fold. Here, as you see, the rash is typically involving the fold, while in diaper dermatitis, it is on the bulges, the areas which are actually coming in contact with the diaper. Like in this patient, the vulva, the thighs would be involved, but the depth of the fold would be spared. Secondly, satellite lesions would not be there. So these 2 points would go in favor of diaper dermatitis, which is not the answer here. So topical zinc oxide is gone. It is not acrodermatitis enteropathica. Oral zinc is out. So the correct diagnosis here demands for a clotrimazole cream, which is option A. Now this as a question, yes, it is one of those questions which are so basic that, it is a possibility that you might end up missing them out. But look at the rash properly. And I'll tell you, there is a NEET PG 2019 question where there is a diagnosis of candidiasis on the neck of the baby, where there was again maceration in the neck folds with satellite lesions. So even though you might have seen the images of neck when you study it in your PYQs, but a similar rash can be there in the groin. You need to be able to differentiate it from the others.
Yes.
That's about it, sir.
Ma'am, it's a very interesting thing. Actually, I'll tell you, if you are a dermatology OPD you are running or you are running a
Yes,
pediatric
sir.
OPD, these will come a lot, and many times they will be coming to me or to ma'am only because they are showing to somebody, maybe a simple MBBS or maybe some other, with all due respect, medicine person, but they do not understand the fine differences sometimes between these three types of rashes. One is a zinc deficiency, one is a typical, benign kind of a diaper rash, and the third is your Candidal intertrigo. They can sometimes have overlap picture, and what sometimes chemist people do, or even these days, jhola chaps, what we call as quacks, they are there. There are creams which are available, which will have zinc, which will have betamethasone, and which will have clotrimazole, and they will give it, and then it will neither fully go away, मर भी नहीं रहा है, जिंदा भी है, मरने भी नहीं दे रहे. That kind of a rash patient will be presenting to you with. So it's like somebody having diabetes. Day he's having insulin, in the afternoon he's having a rasagulla, in the evening again he's having a tea without sugar, at night he's again having something sweet. So his blood glucose is not stable. That is what is happening in these patients also. Making the correct diagnosis is very important. Clinical, yes. Potential MCQ, definitely, if examiner goes in that direction. So we are spending a lot of time just on one slide. Please save it, add these points to the notes. Let's go further. MCQ scenario, it's an easy one. Child with bony pains, petechiae means pinpoint bleeds. Think of thrombocytopenia, think of something else which is causing capillary leakage, and abnormal corkscrew here. Corkscrew here is something like this. Which likely deficiency are we thinking of? Bony pain, petechiae, bleeding manifestation, corkscrew here, everything fitting into a diagnosis of scurvy. So we are thinking of vitamin C deficiency. Ma'am, please take over.
So vitamin C deficiency, clinically, as well as the most common presentations that you see, are bleeding gums. They can sometimes be bleeding into the joints as well, which can present as arthralgia, but it is this bleeding which is a very important symptom. Then this bleeding, apart from gums and joints, can also happen around the hair, which will manifest as perifollicular hemorrhages. And the hair can be twisted in the form of a spiral shape, which is your corkscrew hair. So on the skin, these are the three manifestations that you see. In the systemic manifestations, there are much more, as Sir would talk about rosary and other manifestations. So you have to know a combined manifestations of skin as well as systemic, which will take you to a complete diagnosis. Dr. Sandeep, I'll tell you about rosary. So rosary is the costochondritis that we see. We can see that in rickets. So we lost you.
Unrelated to this, uh, I got a call from Zomato guy who has brought a pizza, and he called me and the internet just went away. Sorry for the interruption. This is the problem with live session. Please continue, ma'am. Sorry.
Sir, we can share the pizza, even though Delhi Chandigarh would be a little difficult.
Yes, it will be difficult, but for those who are listening to it, don't focus on pizza, focus on the scurvy part. So, ma'am
Sir,
has told you about the manifestation. Sorry, ma'am, you were saying something.
no, sir. I was asking you to cover the systemic manifestations.
Yes. So, ma'am has talked about, let me put it like this. What is happening in scurvy? In scurvy, 80% manifestations, not 100%, 80% manifestations can be simply explained by the concept that vitamin C is required for proper collagen formation. Let us go into biochemistry. Vitamin C causes hydroxylation of lysine and proline residues. When hydroxylysine, hydroxyproline are formed, they form hydrogen bonds and they convert procollagen into the mature adult strongly interlinked collagen. Imagine vitamin C is not there, weak collagen, defective collagen will form. Defective collagen is the mainstay of most manifestations occurring in scurvy. This is your INI-CET MCQ 2022, number one. Number two, what when collagen is weak, what manifestations will happen? Number one, patient will have poor wound healing. Why poor wound healing? The weak healing tissue, weak tissue will be formed, and that will not allow a proper epithelialization to happen. So poor wound healing will occur. Remember, poor wound healing can occur in zinc deficiency also. But another manifestation where poor wound healing can occur is scurvy, number one. Number two, the collagen is defective. It is deficient in the small, thin blood vessels, which explains why these patients will have bleeding gums. They will have perifollicular hemorrhages, and due to perifollicular hemorrhage, the hair which arises that will have corkscrew hair. Third, these patients will have subperiosteal hematomas. What is subperiosteal hematoma? Below the periosteum, small bleedings will occur, and these subperiosteal hematomas will lead to bony pains. The bony pain will be so severe in a young child. The parents try to make the child will not stand, child will not walk. Parents will think child has developed a paralysis. We call it as pseudo paralysis. It is mimicking paralysis. So remember, name one micronutrient deficiency where pseudoparalysis is common. The answer is vitamin C deficiency, that is scurvy. Fourth, vitamin C deficiency. Now, think of your ribs. Ribs are attached posteriorly to the vertebra. In the front, they curve like this. Initially, there is a costal cartilage through which they are attached to the sternum. At that part of costocartilage junction, there will be small amount of bleeding and splitting happening because again, weak collagen and some degree of bleeding. And that will cause beaded appearance. So what is seen in these patients is called as scorbutic rosary. Scorbutic rosary can similar manifestation can be seen in rickets also. Scorbutic rosary is always painless and it is angulated because there is some separation happening, some bleeding happening. If a similar thing happens but it is painless and it is rounded, think of rickets. Remember the funda.
So
Scurvy is
scorbutic,
always
so you're saying painful, but you've written painless.
painful. Yes, sir. Sorry. Painful. Scorbutic is always painful. You can remember like this. Vitamin C deficiency is always painful, whereas vitamin D deficiency is always painless. Exceptions can be there, but remember, vitamin C deficiency, in fact, is the most painful condition among all micronutrient deficiencies. There are a few things which are always painful. Making a silly mistake in exam, always painful. Seeing your best friend with your crush, always painful. And scurvy, again, always painful. Remember these three pains, they are always painful and you will always remember them. Fortunately, the good thing is scurvy is becoming less and less common. And even simple tomato juice and simple fruits, guavas and all, you don't need to have citrus fruits. These proper consumption and avoiding too much of milk-based diet can make sure that you don't get scurvy. Treatment of scurvy generally requires 100 to 200 milligram of vitamin C per day. 100 to 200 mg of vitamin C per day. OBGYN says 100 to 200 ml of tomato juice per day for 1 week is also good enough to treat scurvy. This is something mentioned in OBGYN also. Ma'am, anything to add from your end?
Sir, I thought you were saying fortunately scurvy is the only out of the three which can be treated.
No. Scurvy is, ma'am, treatable.
No,
But
sir. Out of the three causes of
आउट ऑफ द थ्री
pain.
यस मैम ट्रीटेबल नहीं देखो ट्रीटेबल तो सब कुछ ही है ना यू सी योर बेस्ट फ्रेंड विद योर क्रश दैट इज पेनफुल बट लाइफ गोज ऑन देन यू move ahead in life so people who are listening to it don't make notes of all the things there are a few things which are meant to be ignored also.
And sir,
um,
one more pain that I see, that pseudoparalysis, one more thing that comes to my mind. Where else do we see pseudoparalysis? Another
let
cause
let the students
specifically
ask. Let
pseudoparalysis
others.
of parrot. Where is
Parrot.
pseudoparalysis of parrot seen?
Where do we see pseudoparalysis of parrot? Live chat. We are looking at it.
I'll give you a hint. It can be associated with snuffles. It can be associated with vesiculobullous lesions, especially on palms and soles. There can be hepatosplenomegaly along with it. What is this taking you towards? and Wimberger sign is positive. That's another confusion between these two conditions. Both have pseudoparalysis, both have a radiological sign that has the term Wimberger in it. I think these are enough hints. Anyone answering that?
Pseudoparalysis seen in scurvy, as ma'am said, pseudoparalysis of parrot is seen in patients with congenital syphilis.
Yeah.
Congenital syphilis. Yes, Kaushik
Very
Reddy has
good,
answered it
Kaushik.
correctly.
Very good,
Nafisa
Nafisa.
Abdul Qadir.
And sir, in the radiological sign also, if you could tell them the difference between the Wimberger and the Wimberger ring sign.
Ma'am, Wimberger, radiology is not there with us. Wimberger ring epiphysis, basically in scurvy, what we find is now there is no space. Let us try to find some space we can write. I'll write it here. In a scurvy patient, whenever you are looking at X-ray feature of scurvy, you will find manifestations like, first of all, there will be Pelkan spur formation. So Pelkan spur is a one-liner which has been asked in NEET PG, number one. Number two, these patients will have a ring-shaped epiphysis. We call it as Wimberger ring sign. Wimberger ring sign. There will be ring-shaped epiphysis. There are three parts of bone: epiphysis, metaphysis, diaphysis. So Wimberger ring sign will be showing Wimberger epiphysis. Third sign in these patients, there will be pencil thin cortex. Pencil thin cortex will be seen. Again, it's a MCQ asked not in NEET PG but in FMG exam, one of the radiology exams. It was asked as a case scenario. Fourthly, these patients will have white line of Frankel. The metaphyseal line, it becomes very, very prominent. That is called as white line of Frankel, which will be seen in these patients. And lastly, second last point, I'll say small micro fractures of the bone will be visible. These are plus minus which can be seen. Anything else, ma'am, you want to add to this extra features of scurvy?
No, sir. All good.
I think we are good to go. Scurvy treatment we have already done. So whatever we are discussing, see, we are not taking it in a way that, the traditional way. We are discussing it in a way that we are integrating pediatrics, we are integrating dermatology, and we are integrating all the MCQs related to this and the facts but you tend to forget sometimes, so that you can come back to the session again and just add these points to your notes. Let's move further because we had promised to keep it very brisk. B12 deficiency. Ma'am, please take over.
B12 deficiency was one of the options, so we have to know how to rule it out. Yes, it does have manifestations on the skin as well as the mucosa, but on the skin, what you see in vitamin B12 deficiency is pigmentation of the skin, which is especially prominent on the palms as well as the periungual area, that is around the nails and the knuckles. These are the areas which, if the patient comes to you with pigmentation, you have to suspect vitamin B12 deficiency. The effect on the hair is opposite. While it is going to pigment the skin, make the skin darker, on the hair, it is going to make the hair gray, that is white. So the effects are opposite on the skin and the hair. It is one of the causes of premature graying of hair, that is also called as premature kernitis. So one of the causes of that is B12 deficiency. On the mucosa with all the vitamin deficiencies, you can see glossitis. Same is the thing you can see with vitamin B12 deficiency also. This is called as magenta tongue in B12 deficiency. So the glossitis that you see on the tongue, this is called as magenta tongue. Apart from skin, there are certain other systemic manifestations also, which sir will cover.
In B12 deficiency, one more important thing examiner will mention, that they will mention the patient is on a vegan diet. This
Yeah.
vegan word, wherever you find, you have to think of B12 deficiency. Now, there are technically speaking three types of diets: vegetarian, non-vegetarian, and vegan. Vegan people will not be taking it's a lifestyle choice, and people will not be taking any animal product, including milk products. But we have some pseudo-vegans also. Like, I was taking a class at one of the session. I asked anybody vegan. One student raised his hand. He said, I said, you are a vegan? Yes, sir. I said, you don't take any animal product? He was like, sir, paneer खा लेता हूँ. मैंने कहा पनीर खा लेता हूँ, then you are not a vegan. He said, no sir, he was insistent, I am a vegan. So this is what we call a pseudo vegan. There is no such thing as pseudo vegan, but in India we create our own categories. For example, you have a category called as vegetarian. There is no such thing as vegetarian. If you eat eggs, you are non-vegetarian. Accept it. Don't try to be morally superior to someone. Again, and then you have people who are non-vegetarian except Tuesdays, Thursdays, and Saturdays. So these categories cannot be defined in any category. I belong to the same. Yes, we have double standards. I have triple standards, ma'am. I go to outside India, then I eat on Tuesday also. I apologize. I'm
I
very
am also, I eat everything on a vacation. Whenever I'm out of my home, it is a vacation for me.
yes. So these Western people, they come to India, they're like mad. What these Indians are doing? But that is there. One way of looking at it is we have our own diversity and diverse food habits. You can laugh at it, but at the end of the day, it is something which is unique to us. And if you look around you in your own family and your own friend circle, you will find all kind of people. So on a serious note, never judge anyone by the diet that they are having. It's a very, very personal choice. But at the same time, if you are solving an MCQ, you get the word vegan, immediately your mind should go towards a B12 deficiency patient. Vegetarian can be B12 deficient. He can be sometimes, other deficiencies also can occur, including if the person is eating processed food and he's a vegetarian, folic acid deficiency can also occur. So, but vegan word will only go in favor of B12 deficiency. What other things can happen? Megaloblastic anemia can happen. Megaloblastic anemia should be suspected where the patient you are able to find macrocytic RBCs, large RBCs where the mean corpuscular volume is equal to or more than 104 femtoliter. Plus, either the bone marrow is showing megaloblasts in the bone marrow, or nobody does bone marrow aspiration these days. If you do peripheral blood film and you find there are hypersegmented neutrophils, hypersegmented neutrophils, how they look like. This is very beautifully described in our pathology lectures. Vandana ma'am has created a very beautiful photographs and a description of that. I'm not a good pathologist, but I'll try to explain. Normally, in mature neutrophil, you have about 3 to 4 lobes of the nucleus. If you find 5% neutrophils having 5 or more lobes, or even a single neutrophil having more than 6 lobes, you think of hypersegmented neutrophil. So either macrocytic RBC with megaloblast or macrocytic RBC with hypersegmented neutrophil, megaloblastic anemia should be thought of. Second thing, these patients will have subacute combined degeneration of the spinal cord, also written as SACD of the spinal cord. It is written as SACD-SC. This is how it is sometimes written. Now, subacute combined degeneration particularly affects the posterior or dorsal columns of the spinal cord. What do the posterior and dorsal columns carry? They carry proprioception and they carry vibration. And these are the early sensations which are lost in these patients. Let me give you a very random information. Stupid way to remember. There was an earthquake someplace. Everyone ran and the building they were able to survive. One person did not come to know that earthquake is happening. He could not feel the vibration. Building collapsed on him, he died. What is the type of micronutrient deficiency? It's a very stupid example, but if you can't feel vibration, you're having problem in posterior column. Which vitamin deficiency most commonly affects posterior column? B12 deficiency. Rarely it can occur in vitamin E and others also, but if you get a question in PG entrance exam, the answer is going to be B12 deficiency. And thirdly, these patients will have peripheral neuropathy as well. So watch out for these keywords: knuckle hyperpigmentation, the glossitis, the photograph which ma'am showed, along with any of these or vegan diet, the answer is B12 deficiency. And regarding the treatment part, remember B12 deficiency is one area where parenteral B12 is always preferred over the oral B12. These days, sublingual tablets are also available, but again, they are not actually approved for use for OPD purpose. So parenteral, whenever you are giving, different regimes are there. The most popular regime is 1 milligram, that is 1000 micrograms should be given daily for about 2 weeks. Then you need to give it either weekly or lifelong, depending upon what the underlying cause is. This is the initial dose that examiner is going to ask you. You can add this point to the notes. Various types of protocols are there. Again, this is not the place to discuss all the different types of protocols. Ma'am, please take over the
This
question.
question we've already covered.
Yes.
This is a child who's presenting with bleeding gums, arthralgia, rosary, and bowing of legs. Which of the following is associated with it? So this is a recently examined asked PYQ. What do you think is the correct answer? Here, yes, you can rule out vitamin A and vitamin K deficiency, but you actually have to make a choice between option A and C. That is, choose between scurvy and rickets as the cause of this manifestation. What is your correct answer?
What is your correct answer?
See, bleeding gums and arthralgia would go in favor of vitamin C deficiency.
Yes.
Rosary can be seen in both. Bowing of legs goes in favor of rickets.
Yes. So which is the better answer?
Yes. Many a times in the exam, you don't have to give the correct answer. You have to give the better answer or the best answer. That is an important point to remember.
So what is the answer? Anyone, you want to take sides? Is it A or is it C?
So we have variable responses. We have mixed vitamin C and vitamin D responses. So I love such situations where there are controversies which have to be cleared. So sir, please clear it for us.
I told you very simply, rachitic rosary is a term which is generally used for vitamin D. Bowing of legs can occur rarely in vitamin C deficiency also, but rickets will never have bleeding manifestation, and rickets is a painless condition. So the better answer is A than C. Maybe the examiner, when he or she, now there are two possibilities here. Number one possibility, it is a recall bias. Means there was not the word rachitic rosary, maybe it was simply rosary, right? We call it as recall bias. Number two possibility, maybe the examiner himself or herself, end of the day we are humans, na? We can make some typing mistakes. But when you look at bleeding manifestation, when you look at pains, it has to be scurvy, right? Remember the funda, scurvy is painful and scurvy has bleeding manifestation. Rickets is painless. Rickets does not have bleeding manifestation. Going by this logic, the better answer is A. And that is your correct answer. Vitamin C deficiency is more likely. Would this question be asked again? Highly unlikely. But if you get a question like this, again, mark according to logic, and you will generally find one or two such questions in every exam. They will never decide your pass or fail. Uh, all of the following favor a diagnosis of kwashiorkor over marasmus except which is favoring kwashiorkor over marasmus. Look at the option, tell me the answer. We are moving into uh, pediatric topic with some derma manifestation. Look at the options, tell me the answer. A, B, C, or D. What is your correct answer? Except word is there. It's a INI-CET, similar to INI-CET. I did not say same, but similar to INI-CET MCQ. Hair sign is seen in kwashiorkor. Yes, it is seen in kwashiorkor. Flaky pin dermatitis can occur in kwashiorkor. Yes, it can. Cellulitis is inflammation of the cellulite, the subcutaneous fat, with edema. Edema is a feature of kwashiorkor. Baggy pants appearance is a feature of marasmus. And I'm so happy to see almost all of you have got it correct. So answer to this question is A. All of the following favor a diagnosis of kwashiorkor marasmus except A, baggy pants appearance. Let us move into the world of PEM. Protein energy malnutrition, two types, kwashiorkor, marasmus. Kwashiorkor is edematous, marasmus is non-edematous. Kwashiorkor has predominant protein deficiency, whereas marasmus has predominant carbohydrate or caloric deficiency. Kwashiorkor child is a non-adapting child. Marasmus is a adapting child. Kwashiorkor patient has increased risk of infections. Marasmus has a slight increased risk of infection. If you look at both of these children, kwashiorkor children appear to be healthy. They have a rounded face, they have edema, but actually marasmic child is a healthier one. Even if he's losing fat, he's the one who's adapting, and so they generally have a better outcome. These are the two types of skin manifestation and the things which you examiner can ask you. Flag sign will be seen in here. Alternate bands of pigmented, depigmented, pigmented, and then depigmented hair will be there. This is flag sign. It indicates patchy nutrition in the child. Patchy nutrition again goes in favor of kwashiorkor. Apart from that, the hair in these patients will be brittle, jaldi toot jayenge, lusterless. There will be no shine in the hair. Plus, they will have skin rash. What kind of skin rash? The most common skin rash is flaky paint dermatitis. जैसे पेंट पुराना हो जाता है, उसकी पपड़ी उतरती है. Similarly, the skin of these children is shed off. You can call it as desquamation or desquamative rash is seen in these patients. Another type of skin rash, less common, but pigmentary changes, uneven texture. You can see crazy pavement dermatitis or crazy pavement dermatosis also in these patients. Ma'am, anything to add?
But in fact, I remember this flag sign in kwashiorkor was a match the following MCQ in INI November 2025. So this is a very recent question. It's an INI November 25 question. Remember, flag sign is seen in kwashiorkor, and so is the fleeky paint dermatosis. Yes.
Yes. And as I said, marasmus is an adapting child. And I always say in my class, if you have malnutrition, if life gives you malnutrition, be like marasmus. You have less infection, better outcome. You are fighting back. Sometimes fighting back is what nature wants to see. We're talking about marasmus, monkey faces or monkey child faces. बंदर के बच्चे जैसी शक्ल, lot of wrinkles on the face. Monkey faces is there because there is loss of buccal pad of fat in these patients. It is a part of adaptation in the child. Plus, if you look at their thighs and skin folds in the buttock region, you will have loose skin folds present. And loose skin folds in thighs and buttocks give rise to the so-called baggy pants appearance. Baggy pants appearance is AIMS MCQ before INI-CET came in 2019. So it's a one-liner question as well. Would they ask more manifestation? Anything can be asked from this topic, but these are the skin manifestations of protein energy malnutrition.
See,
Another one.
when we tell you that this is a previously asked question, that's a PYQ. Yes, you stress upon the PYQ, but you have to read the PYT. It becomes a previously asked topic. So whatever points we discuss, it is imperative that the entire topic is read properly so that you grasp all the points about these questions. That is a very important thing that you have to remember. Please go through the entire topic, not just the questions.
See,
Yes, sir. We can.
we are not astrologers, we are teachers. But our experience says that if you go through this session that we are taking right now, worst case scenario, you will get at least 1 to 2 questions, whether it is NEET PG, INI-CET, or FMG. Best case scenario, a bit of luck on your side, you can end up with at least 2 to 3 questions also. So please go through this video and at these points which we are discussing, add them to your existing notes. Ma'am, scenario.
Yes, this is a recent, I would say, a NEET PG 2025 question. A young child presents with a non-pruritic, that is a non-itchy, hyperpigmented lesions over the elbows, knees, and the buttocks. On examination, hair appears dry, sparse, is lacking luster. Which of the following will be the next step? So the question tells you that the rash is non-itchy, it is present on elbows, knees, and the buttocks. There is a dry lustreless hair which can be there in all causes of malnutrition, so that is not a specific feature. But yes, when you look at the image, in the image you see that there are follicular papules. These papules are arising around the hair. We call them as follicular papules. They are appearing on the elbows. The background skin is dry, it's rough, it's on the elbows. What do you think is the diagnosis, and what would be your next step in management? A very important question, sir. I would say this is asked 3 times in the last 5 NEET PGs. This is that important a question. Yes, we are getting good answers. All of you have made the diagnosis. This is Phrynoderma. And how does Phrynoderma happen? This is overall a state of malnutrition. This is a child with malnutrition. So we can move to the next slide.
It
I'll come
occurs
back
due to,
to
yes.
I'll come back to the answer. We'll first talk about the reason why we have Phrynoderma. The deficiency here is a multivitamin deficiency. You have deficiency of vitamin A, B, E, K, as well as the essential fatty acids. Now, specific deficiencies can have reasons, can have specific situations. But when you have these multiple vitamin deficiencies, there has to be something that is leading to a overall reduced intake. So this is a child who has malnutrition, who might have a dry skin, who might have dry lustreless hair, and this is a child who is now presenting with a rash on elbows and knees. And when you look at these deficiencies A, B, E, K, which of these deficiencies you think is the most important to rule out, most important to check for? that is vitamin A deficiency. And vitamin A deficiency can lead to xerophthalmia. So, what would be your next step in management? Going back to the question, you see, next step in management would be an ophthalmologic examination because you want to rule out xerophthalmia. Vitamin D, vitamin B12, they may be low, they may not be low. That can be an additional investigation that you do in these patients, but that would not be the next step in management. Skin biopsy is not really needed for diagnosis. This is a clinical diagnosis that you make. So the correct answer to this would be option A, that is ophthalmologic examination. When you look at the lesions, you see that they can be present on elbows, knees, and as the image shows, these are all follicular papules which are arising on a dry, rough skin. This background dry, rough skin is a very important thing. You see at the other two small images, you see lesions on the buttocks as well as the knees. And this dry, bumpy appearance of the skin is similar to what a toad looks like. So this is also called as toad skin. Another name for Phrynoderma is toad skin.
Toad skin. Toad is the brown one. Frog is the green slimy one. If you move your hand over a frog and it is smooth, it is a frog. If you find it a bit, granular, it is a toad. So toads are the ones which are
So, you
brown.
know what? Actually, when I was reading about toad skin in Phrynoderma, it's been a while, but I had to know why it is toad and why not frog. So, I actually read the differences between a toad and a frog. A frog has a smooth, slimy appearance, while toad is the one which has the bumpy and the rough skin. And yes, there are many other differences, but yeah, that's a subtle point. These are all the subtle differences that you have to know for your exams, like a frog versus toad, turtle versus tortoise. We go back,
Ma'am,
we read these.
I came to know in first year MBBS itself. For those who don't know, I belong to that MBBS batch of our country, which was the last batch to do frog experiments. तो frog experiment हम कहते थे, बाद में पता चला वो toad होते थे. So after I passed out, after not went into the second prof, there was a notification and frog experiments were banned throughout the country. So मैंने बहुत frog experiment किए हैं, unfortunately बहुत मारे हैं frogs. You have to kill them to get the experiment done. So that is a bad karma I'm carrying. But that was the time we came to know that slimy one is a frog and brown, that rough one is a toad. I'm quite sure these students are not going to forget now. So, see, useless information stays in our mind for a longer duration. Attach something useful to it so that you can remember it better.
Yes.
So, ma'am, you want to take it up?
This is another question. This is another NEET PG PYQ only. A child with malnutrition, multiple follicular papules on dry skin on elbows and knees. See, there is no image here. You have to make out the diagnosis from reading the text. This is another thing that I want to emphasize upon. See, we as a matter of habit tend to just look at the images, skim through the images, and we think our topics are done. But when you look at the recent patterns, which are ever evolving across all these exams, you see that the emphasis is more upon the description. They give you a clinical scenario, they describe the diseases in terms of skin, they would describe the skin lesions as well. So I would say, yes, you do see the images, but whatever you're reading in the text along with that, try to identify the points of the text in the images and vice versa, so that you know what you are dealing with. When you read this question, there is a child with malnutrition with multiple follicular papules on dry skin on elbows and knees. You have to go back in your mind, think about Phrynoderma. Another hint in the question, alleviation of skin lesions was noted with vitamin supplementation. Alleviation means resolution, improvement. So improvement of skin lesions was noted with vitamin supplementation. Again, that takes your diagnosis to Phrynoderma. None of the other options mentioned, keratosis pilaris, Darius disease, lichen planus, would be responding to vitamin supplementation. I've just taken this as an opportunity to help you differentiate between the other options. Lichen planus, would be itchy purple papules, nowhere close to what is mentioned here, distribution on the flexures. Darius disease is a transient acantholytic disorder. You would have warty, hyperpigmented papules on the face and the neck. Again, not something that you see here. And It will not even respond to vitamin supplementation. B, that is keratosis pilaris, is actually a quite frequent confusion in the exam, because when you look at it, even if you don't know you're dealing with Phrynoderma, you read keratosis pilaris. Pilaris means hair. So many of you might think that, okay, this is related to hair. The question is saying follicular papules. Maybe this is the correct answer. But this is not the correct answer here. If you look at lesions of keratosis pilaris, these are also slightly reddish to skin colored follicular keratotic papules. Keratotic just means slightly hard. So these are papules which are slightly hard. They are around follicles. So these are called as follicular keratotic papules. But it is the distribution that is important. You look at the morphology, that is similar, but it is the distribution that is important. This is on the extensor aspects of your arms, your back, your thighs. In fact, any of you who's towards the southern aspect of the country, you're wearing half sleeve t-shirts, if you feel your skin on the outer arms, you will feel slight bumpiness on your skin. That is all keratosis pilaris. We all tend to have it, especially those people who have a drier skin, they tend to have it. In terms of another MCQ, you will read this is associated with atopic dermatitis. So association of KP is with atopic dermatitis. It is a common finding on the arms, thighs, and the back. It is nowhere related to malnutrition. It will not respond to vitamin supplementation. So even though the description of follicular keratotic papules remains the same, but all other things are different.
Ma'am, in fact, association with atopic dermatitis is a super specialty MCQ in pediatrics. This is one of the MCQs. So, ma'am just mentioned. Uh, don't worry, we are not training you for super specialty. We are just mentioning it because it is coming as a part. So, you understand, if you understand the topic and you do it in a proper integrated way and you are able to distinguish from common things, even if it is a tough question, you are in a position to answer it. So, in fact, keratosis pilaris, even we pediatricians sometimes get it wrong. So, it is the dermatologists who are the experts in this. Now, iron deficiency anemia, ma'am, this is something students can easily identify. You want to elaborate on this?
So in terms of dermatology, patient would present with a dry skin, with dry hair. It might also lead to a diffuse hair fall, which is chronic telogen effluvium. And when you look at the nails of these patients, there is a specific finding which you can see on the nails, that is a spoon-shaped concavity on the nail, which is called as koilonychia. Now, koilonychia can come as an image-based question. It can come as a part of a constellation of signs and symptoms that you see, but this is an association of iron deficiency anemia that you see.
Apart from that, when you talk about iron deficiency anemia, if it is a child, the child will have manifestations like pallor, visible pallor will be there, paleness of the skin. Child will have fatigue. Now, very important thing is child has anorexia and irritability. Many times the parents feel that my child is very irritable, crying without reason, and khata nahi hai अच्छे से. Many times it is actually iron deficiency anemia which is the cause. So anorexia and irritability are one of the important behavioral features you will see. Plus, these children will have tendency to eat non-edible substances like pica. So pica will be there. Someone is asking till what time this live is present. Next 5 minutes we will finish off. But if you leave before that, the last point I tell you will be asked in your exam. So pica is ingestion of non-edible substances, which is significantly more common in iron deficiency anemia. So this is iron deficiency features along with the usual things like koilonychia, sometimes platinichia, that is flat nails will be there. But generally examiner puts a question on the koilonychia because this is more dramatic. And you can always go for these iron tests. You can go for MCV, MCH, MCHC, RDW. You can go for ferritin levels, total iron binding capacity. It's complete hematology picture. What we are thinking of is two MCQs which are asked in NEET PG exam. What is the dose of iron in iron deficiency anemia? The dose you have to remember, the dose was asked in mg per kg, 3 to 6 mg per kg per day. If you remember this dose, it's a NEET PG PYQ. It needs to be given for 4 to 6 months. According to OPGI as well as Nelson textbook, it takes about 2 to 3 months for hemoglobin normalization. Another 2 to 3 months are needed for ferritin stores to be replenished. So total duration is 4 to 6 months. And when we calculate the dose, it should be elemental iron, right? It should be elemental iron. So that elemental iron you can always calculate. Details examiner will not ask you. Second is response to iron therapy. INI-CET MCQ, identify the incorrect statement. When you start iron therapy in the patient, within first 24 hours, there is decreased irritability, increased appetite. So very, very important. Indirect MCQs asked in the exam. Between 36 to 48 hours, bone marrow response comes in. Reticulocytes, the immature RBCs, they tend to start rising between 40 to 72 hours, but they peak at about 5 to 7 days. Hemoglobin level generally starts rising between 1 to 2 weeks. The range given in Nelson is 4 to 30 days, and replenishment of stores takes another 1 to 3 months. So this is the therapy, this is the response to iron therapy that you need to remember. What if you can't remember everything? Remember, subjective symptoms appear earlier compared to improvement in hemoglobin. Improvement in hemoglobin generally occurs after subjective improvement. This is what you need to know. And as I promised all of you, we will not take much of your time. The session is done. We have covered about 18 to 20 MCQs without you, some of you not realizing it also. And we have taken some of the controversies as well. I hope that you are going to benefit from it. For any further doubts or similar sessions, you can follow ma'am's page. Ma'am puts a lot of images, and ma'am has a very high yield in image-based questions when it comes to dermatology. So if you want to be a dermatologist, at least you should be good in dermatology for NEET PG. Please follow ma'am, and you can follow me also. Follow us at least till your exam is done. The day you pass the exam, thank you. Unfollow us, no problem at all. A new generation will come in. Right. Thank you so much. Thank you for the time. Ma'am, anything
Thank
to add?
you. No, sir. Excellent points we've added. I want you all to just read the topics if you have time so that it is cemented and it will be there in your mind forever, or at least till you give your exam. That would actually solve the purpose of the session if you cement it in your mind by reading it.
And I'll have to reheat my pizza, but now I can have it in peace. Okay. Thank you, everyone. Thank you, ma'am. Thank
Okay.
you for your
Good
time.
night.
Bye bye. Take
Good
care,
night,
everyone.
everyone.
Good night.
Bye bye. Good night.